Valvular heart disease. Before valvular heart disease, we will study about off-pump coronary artery surgery and minimal access surgery in short. Off-pump coronary artery surgery. Off-pump coronary artery surgery. Coronary artery bypass grafting or CABG without the use of CPB is well established. Without the use of CPB, cardiopulmonary bypass is well established and increasingly popular method that may be combined with a minimally invasive approach or carried out through a conventional sternotomy sternotomy. It offers the advantages that it avoids the physiological stress associated with coronary cardiopulmonary bypass and to some extent the aortic manipulation that can lead to neurological injury through atherosclerotic embolization. Since the introduction of cardiac stabilizing devices such as Octopus, off-pump coronary bypass, off-pump coronary artery bypass, off-pump coronary artery bypass grafting has become widespread. Off-pump coronary artery bypass using Octopus stabilizer to perform the distal anastomosis. Since the introduction of cardiac stabilizing device such as Octopus off-pump coronary artery bypass by off-cap grafting has become widespread. One of the concerns, however, is related to the quality of anastomosis carried out on a beating heart and bloody field that can limit the surgeon's vision. The advantages of off-pump surgery over on-pump surgery has recently been questioned, especially with the development of mini bypass pump. Which offer a closed circuit mini bypass pump which offer a closed circuit and minimal unphysiological surface area, which offer a closed circuit and minimal unphysiological surface area This reduces pro-inflammatory activation, but at the same time allows the surgeon to operate on a still bloodless heart. This reduces pro-inflammatory activation, but at the same time reduces pro-inflammatory activation. It reduces pro-inflammatory activation, but at the same time allows the surgeon to operate on a still bloodless heart. However, there is still no evidence to support the superiority of any of the above mentioned techniques, and the final decision is usually based on the surgeon's skill and required operation. And finally, we can say There is still no evidence to support the superiority of any of the above mentioned techniques, and the final decision is usually based on surgeon's skill and the and required operation. Now, minimal access surgery. Minimal access surgery. Minimally invasive direct coronary artery bypass, or minimally invasive direct coronary artery bypass grafting is performed through a strategically placed minimal access incision. Access incision, and so avoids all invasive aspects of the conventional CABG. Through an anterior submammary incision, the lemma can be dissected down with the aid of a thoracoscope and grafted to the LAD with the use of thoracoscope and grafted to the LAD. More lateral mid-cap, that minimally invasive direct coronary artery bypass incisions allow access to other coronary vessels, including branches of the circumflex artery. Patient selection remains, at least at present, a restriction to the over-increasing minimally invasive methods being developed, although not yet critically evaluated. One particular approach is to combine mid-cap, typically Lima or LAD, with PCI to other less accessible coronary arteries. Hybrid coronary revascularization, although not yet critically evaluated. One particular approach is to combine mid-cap, typically Lima or LAD, with PCI to other less accessible coronary arteries. That means hybrid coronary revascularization. Hybrid coronary revascularization. Now our main topic, valvular heart disease. Introduction. Valvular heart disease introduction. Early surgical management of the valvular heart disease concentrated on valvular repair. The heroic early procedures for valve stenosis were closed, and therefore blind commissurotomies. They were replaced by open procedures with full visualization, allowing precise repair and replacement. The fast prosthetic valve replacement. Fast prosthetic valve replacement were performed by Harkin in 1960. Replacing the aortic valve. Replacing the aortic valve. Followed by a mitral valve replacement. This is mitral valve. For mitral valve replacement by star a year later, that means in 1961. Continued improvements in perioperative care, myocardial protection, and in particular the development of prosthetic heart valves have improved long-term hemodynamic results, provided symptom relief and prolonged survival. The majority of the valvular operations involve surgery on the aortic or mitral valve. Tricuspid and pulmonary valve surgery. This is tricuspid valve and this is pulmonary valve. Tricuspid valve and pulmonary valve. Tricuspid and pulmonary valve surgery is rarely undertaken in isolation. It is rare. Comparing options for heart valve surgery. Comparing options for heart valve surgery. Valve repair. Advantage: preservation of integral structures, improved hemodynamics over valve repair. Preservation of integral structure. Preservation of integral structure. Valve repair. Valve repair advantages: preservation of integral structure, improved hemodynamics, avoid long-term anticoagulation. Disadvantages include technical difficulties, variable failure rate. Mechanical valve surgery, heart valve surgery. Advantages are readily available, extensive experience of use, needs lifelong anticoagulation, susceptibility to infection. Advantages also includes used in any group, durability lifelong. Stented heart valve surgery. Advantages are readily available, short period of anticoagulation. Disadvantages: limited lifespan. Stentless, readily available, probably better hemodynamics with less outflow tract obstruction, short period of anticoagulation. Limited lifespan, more difficult to insert. Homograft. No anticoagulation, improved hemodynamics, long-term outcome uncertain. Not readily available, technical difficulties. Not readily available, technical difficulties. Surgical anatomy. Heart valves function to maintain heart valves function to maintain heart valves function to maintain pressure gradients between the cardiac chambers and to ensure an unidirectional flow of blood without reflux through the heart. The aortic valve is tricuspid. The aortic valve is tricuspid with semilunar leaflets attached to the aortic wall. The aortic valve is tricuspid with semilunar leaflets attached to the aortic wall at the annulus, with the aortic sinuses being above the base of each leaflets, two of which form the origin of ostium of the coronary arteries. Two of which form the origin or ostium of the coronary arteries. The intrinsic shape of the aortic semilunar valve. The intrinsic shape of the aortic semilunar valve allows blood to leave the ventricle during systole, during systole, during to leave the ventricle during systole, and prevents regurgitation or blood flow during diastole. If disease leads to disruption of the leaflets or the annulus, valve function will be affected. The mitral valve is bicuspid. The mitral valve is bicuspid. The more anterior cusp is larger in area and lies between the orifice of the mitral and aortic valves. The leaflet, like those of the aortic valve, are attached to the annulus. The leaflets join at two commissure and supported by a subvalvular apparatus consisting of chordae tendineae or papillary muscle. The papillary muscles contract in ventricular systole. The papillary muscle contract ventricular systole, pulling the cusps toward the atrioventricular orifice and holding blood within the ventricle. The proper functioning of the mitral valve depends on the integrity of the annulus, leaflet, chorda and papillary muscle. If surgical correction is required, emphasis is on the preservation of these structures when possible. Surgical options for heart disease. The disease the surgical options for heart valve disease. The decision of whether to repair or replace the diseased valve depends on the underlying pathology, the severity of the disease, and quality and/or involvement of the surrounding supporting structures. Generally, repair is increasingly favored when possible in mitral valve disease. When possible in this is mitral valve disease. Generally, repair is increasingly favored when possible in mitral valve disease, particularly in degenerative mitral regurgitation. Degenerative mitral regurgitation, in which it has been shown to have long-term outcomes. Repair is the operation of choice in tricuspid valve disease. Repair is the operation of choice. In case of tricuspid valve disease, repair is the operation of choice. But aortic valve surgery generally involves replacing the diseased valve. In case of aortic valve, it needs aortic valves, it needs replacement. It needs replacement. Important factors in selecting the type of procedure and prosthesis include the patient's choice. Important factors in selecting type of procedure and prosthesis, including the patient's choice, age, existing comorbidities, and the need for anticoagulation. Because of uncertainties about its lifespan, there is debate about when a bioprosthetic valve should be used. When a bioprosthetic valve should be used, with most accepting its use in those over 60 years. The need for anticoagulation may have an impact on choice of valve, particularly in women of childbearing age, the elderly, the presence of congenital or acquired bleeding diseases, when there is need for further major surgery.